The next speaker is Luc VIRLET, which is going to speak of dyslexic children have altered cross-modal processing that is improved by proprioceptive therapy in correlates with reading abilities, a pilot study.
Merci. Thanks. Hello. Thank you for your invitation and you're welcome to the iFAB to speak of dyslexia. I am very honored and happy to speak on dyslexia between Patrick Kersia and Marc Janin. I am Luc VIRLET, GP and PhD student under the supervision of Cédric Bonnet, Laurence Parot of the language team of SCALab, University of Lille, and Professor Patrick Perquin of the University of Amiens. Dyslexic children have altered cross-modal processing that is improved by proprioceptive therapy in correlates with reading abilities, a pilot study. Following Céline Capet's intervention, I will use the term of multisensory integration disorder. While the participation of the podal modality in the correction of labial vertical heterophoria is very important in proprioceptive therapy for dyslexic children. Because there is a causal link between labial vertical heterophoria and the reading skill of dyslexic children, and the use of neurosensory stimulation of the plantar soles is an element of the correction of labial vertical heterophoria. I will demonstrate this statement with the result of the PROPHODIS study. Dyslexia is a pathological reading delay that resists of intervention, occurs in children of normal intelligence without sensory disorder, lack of education, or other explanatory causes. Dyslexia is an automation disorder. Dyslexic children have multisensory integration disorder of perceptual and spatial order shown by Patrick Kersia. Firstly, of perceptual order with the presence of sound-induced visual scotomas. Secondly, of spatial order with the presence of labial vertical heterophoria. Proprioceptive treatment stemmed from the work of Lisbon School of Martin Tacundia and Orlando da Silva. Proprioceptive therapy have two axes. The first, to improve sleep disorder, with breathing exercise and sleep position to limit micro-awake during REM sleep, which disrupt the transition to long-term procedural memory. The second axis, to correct labial vertical heterophoria, firstly by use of trigeminal layers of active prisms and by oral neurostimulation called ARF of Marino and Villeneuve. Secondly, by use of neurosensory stimulation of the plantar sole. Some of you were able to participate in the workshop on this subject conducted by Marc Janin. Two hypotheses. Proprioceptive therapy improve multisensory integration disorder, LVH, and sound-induced visual scotoma. Secondly, there is a causal link between labial vertical heterophoria and the reading skill of dyslexic children. Methodology, it was a randomized study on 9 months, a priori power equal to 0.9. Inclusion criteria were dyslexic children, girl or boy, age 9 to 14, with delay of 2 standard deviations, more than 2 years of speech therapy. All dyslexic participants receive speech therapy, and by randomized selection, we added a proprioceptive therapy. We randomized 27 dyslexic children. We will present the result of 19 dyslexic children from whom we have all pre- and post-test assessment. We added a control group of 9 normal reader children. Multisensory integration spatial order, LVH, is determined by the presence of vertical foria in 9 coded proprioceptive stimuli. Maddox proprioceptive index indicates the number of vertical foria variation. The absence of variation corresponds with the vertical orthophoria, MPI equal to 0. The presence of at least one variation corresponds with the presence of labil vertical heterophoria, MPI equal to 1 to 8. It is the lability of spatial location. Multisensory integration of perceptual order, the soon includes visual scotoma, are functional scotomas. The spatial distribution of visual scotomas were stochastic. Here, clinically, we are interested in determining the lowest frequencies necessary to obtain soon-induced visual scotomas. We constructed an index from 0 in case of no scotomas, 1 for speech, and 11 for a sound at 63 Hz. Assessment criteria for pre- and post-test as 9 months. For multisensory integration disorder were the MPI and the VSI. For reading, firstly, the oral reading with the C-index of the Alouette art test. It is the number of words correctly read in 3 minutes. It is a clinically test. Secondly, the silent reading by objective measurement of eye movement, therefore awarding the BS of oral language use. It is a laboratory test. We use an eye tracker, iLink 1000. With assessment of the gaze duration, it is the time of fixation of the word, including refixation. The gaze duration corresponds with lexical access. It is the word reconnection time. Lexical access distinguishes dyslexic from normal reader and children from adults. And the effect of the word frequencies with the gaze duration of 20 words calibrated in low and high frequencies word. This is a marker of the reading automation processes. Results. At the baseline, all dyslexic children have multisensory integration disorder for spatial lability and for visual scotomas. For the spatial lability at the baseline, there were no differences between the speech group and in orange and the proprioceptive and speech group in blue. At 9 months, 70% were corrected and stable, only where proprioceptive therapy was added. For the visual scotoma index, at the baseline, there were no differences between both groups. At 9 months, 50% were scotoma-free, only where proprioceptive therapy was added. Proprioceptive and speech therapy improve multisensory integration disorder. At 9 months, only 7 dyslexic children were stable in vertical orthophoria, all from the PhD group. 12 remain in labil vertical heterophoria. In case of stabilization in vertical orthophoria, the results show for silent reading. In first, for gaze duration, at the baseline, both groups of dyslexic children differ of the control group. At 9 months, there is no differences between the control group and the vertical orthophoria group. For vertical orthophoria group, we observe a normalization of the gaze duration, is an improvement of lexical access. This notion is very important because the improvement of lexical access implies an improvement of direct access, i.e. visual, and indirect access, i.e. phonological, according to the dual pathway model. And lexical access distinguishes dyslexic from normal reader. Here, we cannot distinguish dyslexic children with vertical orthophoria from normal reader. For the high frequencies world, we observe too an improvement of lexical access. This is a marker of the improvement of the reading automation processes through the increase of direct access world. For oral reading, the differences in the gain of C index equal to 2.46 standard deviation, with a major size effects Goens D equal to 1.23. Average Goens D in dyslexia intervention equal to 0.37. These results show if we correct the labial vertical orthophoria in vertical orthophoria, we improve the reading and automation processes of dyslexic children. We improve the reading ability of the dyslexic children. Oh, sorry. We improve the read ability of dyslexic children in clinical and laboratory tests. We confirm our assumption. Dyslexic children have multisensory integration disorder, improved by proprioceptive therapy. There is a causal link between labial vertical heterophoria and the skill reading of dyslexic children. The two main limitations of the study was a small sample size, and we had not determined the part of every element of the proprioceptive therapy, i.e. sleep, prisms, arts, and plantar neurostimulation. The two main strengths of the study were the objective assessment of silent reading, the strong effect size at 1.23. To conclude, these results and their interpretation raise many unanswered scientific questions. All dyslexic children in this world have multisensory integration disorder. They have a proprioceptive dysfunction. Proprioceptive therapy is effectiveness in dyslexia. There is a causal link between labial vertical heterophoria and reading automation processes in dyslexic children. We can help dyslexic children only if we correct the labial vertical heterophoria. It is a multidisciplinary job. Today, in dyslexia, the posture explains nothing. It undergoes. To summarize, we can say a little stimulation for the foot, a big step for reading. Thank you for your attention.
Thank you very much, Luc. Merci beaucoup. Maybe you have some questions. Yes. Merci, Alexia. You have the microphone under you.
Yes.
Hello. It's wrong.
Is it on? I come across dyslexic young adults.
Okay.
Is it on now?
Yeah.
In the university, I come across dyslexic young adults. Your study is about children. Do you think that the methods you use would be appropriate for adults, or is it too late at that stage to have an effect?
It's appropriate for adult at all age.
Thank you.
In clinical evaluations, the questionnaire we give from children and from adults when you find some symptoms, and when you ask how you have some feeling for reading or memory, anyway, if you have doubts, I take off the questionnaire and see what's happened. And sometimes you have score over 50 or 73, 100, no problems with adults. The difficulty is to treat adults because the remanence of the system is more incur. And so it's very difficult because the process to take off these processes of compensation, it's longer than for the children. But for the children, the difficulty for the participations of the children on this treatment, because you know it's sleeping correction, proprioceptive corrections, ophthalmology corrections, insult corrections, it's a lot of time. But we have some result, very nice. More questions? So?